I'm Kerry Rogers. I'm an associate professor in the Division of Hematology at The Ohio State University. So I think Dr. Ahn and I had a very nice debate about can BTK inhibitors be discontinued, and I had the no side of the question, which certainly was the side I'd thought about less. I feel like as an academic interest, I spend more time thinking about can we do that for the reasons she nicely outlined, expense, toxicity, things like that. So I know was the side I thought about less, but I do think there's actually good points on both sides of the fence for that one. And you're right, it was very compelling to see some of the same data, but with different takes on it. I did reframe the question as should BTK inhibitors be discontinued, because we all know they can be at this point. My main argument was just that responses develop slowly over time with BTK inhibitors, which we're aware of by now. So if you stop them, shortly into treatment, you don't really get the maximum leukemia reduction. You don't see the same level of complete remission rates, things like that. And the progression-free survival isn't expected to be the same if you stop them early too. And we kind of see that from patients who discontinue for adverse events, which will always be a thing that people can't tolerate it. But people discontinuing for adverse events, like in the first couple of years of first-line treatment, usually need treatment within another year or two. So that really suggests you're not maximizing your benefit with a fix or a strategy to discontinue it. And if you continue BTK inhibitors long-term or have a continuous treatment strategy, really I think that's the best results we have in CLL today. I had learned at the European Hematology Association meeting this year in 24, the median progression-free survival with first-line ibrutinib and RESONATE-2. Dr. Berger presented this. It's actually 8.9 years, and I've not seen anything like that in CLL. For example, our institution has a 3-drug combination, ibrutinib, venetoclax, obinutuzumab, given for a year. Median progression-free survival in our smaller number of 25 patients treated with this as an initial therapy was 7.4 years. Dr. Ahn's point is that 7.4 years is fantastic for a 1-year treatment, and I don't want to minimize that, but it's certainly not 8.9 years. So, there's very good data now supporting that in patients with TP53 disruption, deletion 17p or TP53 mutation, you get similar results to those without that high-risk feature in their CLL with a first-line continuous BTK inhibitor strategy. So I think these are the major reasons not to discontinue a BTK inhibitor, and she outlined some very good reasons why one might do that. I think as a field, one of the most exciting things now is we have some really good drugs, and so trying to decide how to combine them, how to sequence them, what might be best in the long run for an individual is going to take some time to sort out, but also is a really interesting thing we're going to have to think of as a field. Is it better to do a continuous BTK inhibitor, maximize your progression-free survival, then go on to something else? Or is it better to do the combination fixed duration strategy, have time off treatment, then go to something else? What's going to be best? Fortunately, people do so well, it will take decades to sort out, and we'll have newer drugs by then. But I think the debate really brought up some of what I think the more interesting questions are in the field about how to use these drugs. That sort of also kind of gets into what I think is really exciting about CLL right now. And then something that definitely wasn't a part of the debate I was having with Dr. Ahn, but was mentioned this session, was things for treatment options for patients that don't do as well as what Dr. Ahn and I were talking about, which is people taking a BTK inhibitor that likely hadn't taken it before, right? And that is, Dr. Kate covered some options for Richter's, which I think is definitely an area of unmet medical need. None of the data looks outstanding yet, but I do think that this is an incremental improvement over what we could expect with prior therapies, and just the idea that we're now studying novel therapies or understanding that this is what we really need to be doing in this space, and continuing to work on an organized fashion, I think is really important. To see drugs like epcoritamab tried there is just, I think, really exciting. And then Dr. Ritter presented some nice data trying to understand who gets the better responses with lysocell CAR T-cell therapy. In CLL, in the largest study with lysocell, it looks like only about 1 out of 5 patients get the duration of disease control that they are wanting, which is, getting a complete remission and getting extremely long, years of disease control from it. And I think 1 out of 5 people expecting to get that response is really not what we're hoping for. So some of this work to understand what are the risk factors for achieving that response or not is really important, and really to see that like our CLL prognostic features, which we care about so much and matter a lot when we're talking about targeted agents impacting the CLL cells, really like deletion 17p aren't making a difference with these cell therapies. We're talking about immunotherapy that cares less about the cell biology because it's targeting the cell by the immune system, and looking at things like disease bulk being bigger features there. So I think making sure that while it's important we sort out what best to do for our patients where we expect good outcomes for the next multiple years, which is what Dr. Ahn and I were talking about with our debate about discontinuing BTK inhibitors, is important, but it definitely doesn't mean that the field should forget that patients with Richter's or with double refractory or certainly double exposed disease, having taken both a BTK inhibitor and a BCL2 inhibitor, either to resistance or a substantial degree, don't have the same disease expectations, and will be extremely important to continue to work on newer therapies for them and eventually move those therapies earlier, and maybe that'll shift the debate. That's a good question. So I do think that when we're looking at like the most common combination to get really deep remissions is that with venetoclax and a covalent BTK inhibitor, or really a BCL2 inhibitor and a BTK inhibitor. If zanubrutinib is going to start replacing ibrutinib in some of those, and definitely, I mean, zanubrutinib is being studied and has been studied in combination with venetoclax. There's currently a study with zanubrutinib and sonrotoclax, which is a newer BCL2 inhibitor. So I think that, you know, venetoclax has been the only drug with that mechanism that had like the clinical kind of backing and approval. I think it's important that we have other drugs we're studying that are BCL2 inhibitors. Some of them have like some BCL-XL activity or like, you know, slight variations, which is important. And so drugs like sonrotoclax I think are really important to have, and understanding who most benefits from them and what combinations are best is going to be key. But yeah, I think both acalabrutinib and zanubrutinib have been studied with venetoclax. Zanubrutinib obviously with sonrotoclax now, and I think continuing to have BTK inhibitor BCL2 combinations that are different. You might have said like, oh, why don't we quit ibrutinib for BTK inhibitors for covalent ones? Like, did we need more? But I think like having different drugs that have different aspects to them that might be more appropriate for different patients, you know, less hypertension with acalabrutinib, certainly better cardiovascular safety with acalabrutinib and zanubrutinib is really key. And, you know, definitely switching for intolerance between these drugs is really key. And we now have a group of drugs that are non-covalent BTK inhibitors, which I think are also going to be combined with BCL2 inhibitors. So like pirtobrutinib and venetoclax, nemtabrutinib is being combined with venetoclax, and then BTK degraders, which are not really an inhibitor but remove the protein, I think are still earlier in development, but most of us are expecting at some point they'll be combined with BCL2 inhibitors. One thing that really matters is we have these two good targets, so we're trying like, how do we target these better? Is degrading better? Non-covalent? Covalent, you know, okay, so is a little bit more BCL-XL inhibition than, you know, venetoclax has important. How do we more safely do this? And that's good, but I don't think we want to forget that it's important to have new targets and new drugs too. I don't think the field should just decide, okay, we have two targets, that's it. Because I'm sure there's something else out there that, if appropriately developed, could improve the lives of our patients. Yeah, so I just don't want us to forget that other things need to happen as well. You know, I think bispecifics are now being tested in CLL, which is really important, kind of as an immune therapy. It's not like we can cure CLL with frontline therapy, so this is going to continue to be an issue.